Hello, good evening. Uh, Welcome you all in the Society of Fetal Medicine East Delhi Ghaziabad chapter, which is organized with the Delhi Gynae Forum East Delhi chapter. Without wasting any time, I'm inviting Dr. Sharda Jan ma'am, who is the General Secretary of core uh, team of Delhi Gynae Forum, and it doesn't need any introduction in the ops gynae circle. Please, ma'am, for the welcome address.
Dr. Shadajan, you have to unmute yourself.
Ma'am, we cannot hear you, ma'am. Please unmute yourself, ma'am.
Dr. Shadajan, you're not yet audible. We have to unmute the bottom left button. Yes.
For this, I think technology these days bother you at times. Welcome everybody who's listening us live in this joint session done by Society of Fetal Medicine and Delhi Gynecologist Forum East. And my greetings to everybody who's listening for a happy learning. And the topic today has been well chosen, thick, NT, and its outcome. I was seeing the flyer and was time given to me was 10 minutes. So I will just unfold the story. I vividly remember 50 years back on 18th of December, I was selected at PGI Chandigarh. I joined the department, I stayed on there. During my 10-year stay at PGI, first as a trainer and then as a faculty, I did not see ultrasound machine. So these were my formative years when there was no training as far as I'm concerned on ultrasound. And now this machine has become a very integral part of the professional life of gynecologists. Not only I find these days that every gynecologist is missing something if the ultrasound machine is not around. It is making a major role in the life of a pregnant lady also. When the 21st century dawned, people in UK were still debating how many ultrasounds. One was difficult. And today this lady doesn't count the numbers, how many ultrasounds you order. So from one ultrasound, which was done at 20 weeks, we've come down to know its importance in early pregnancy, in management of infertility. And we find, a lot of things have been changing. When she's close to delivery, now there's a consensus has almost come between a gynecologist and a patient that we give a go-ahead signal to her for delivery. Again, we check everything. In between, I saw that there was a tussle between gynecologists and imaging people. And they questioned the training and the quality of her training. And I think that has settled for good. And that's why there's a joint meeting between the imaging experts and gynecologists together. Now, this particular society is imaging experts, fetal medicine experts, and gynecologists. And I will say we are still at the receiving end. I'm a teacher myself, and I believe knowledge from all corners is welcomed. And when it comes from Guru of Gurus, then any time of the day, it is welcomed. My knowledge as far as ultrasound is concerned has greatly increased tremendously since the time the Delhi Gynecologist Forum decided that the gynecologists should be trained in transvaginal sonography. So they are independent when they manage patients of infertility. They're independent to manage cases up to 3 months, to diagnose pregnancy, to know abnormal pregnancy, to pick up multiple pregnancy, to know, the abnormal outcomes like incomplete abortions, missed abortions, and things like that. And I think, to a large extent, still quite a few of people are getting settled in that particular things. When it comes to nuchal scan, very clearly as a gynecologist leader, I can say, in 8 metros, gynecologists are aware about it. 50% of private practitioners use this particular technology. But when it comes to in the city of Delhi, the people who are delivering in government setups, whether they are getting this particular scan done or not, I have a big question. When I've left Lady Harding Medical College, 3 investigations were done for pregnant patients. 1 hemoglobin, urine, blood group, and VDR. So I do not know how much each and everybody is getting this kind of things. I'm no expert in fetal medicine, but developed a great expertise in managing high-risk pregnancy, especially the BOH and medical disorders in pregnancy. And we had no other alternative but to pick up best of the surgical skills which are required for obstetricians. I feel, there is a term these days which is called sonoembryology. You learn embryology through ultrasound. And here, there's a study of fetus and the embryo up to 11 weeks. My suggestion to Dr. Khurana will be extended to 13 weeks. As a gynecologist, I can say, when we tell our patients and her relatives, आपके 3 महीने निकल जाएंगे तो your 90% of problems are over. I'm sure Dr. Khurana will also say the same thing. That आपके 3 महीने हो जाएंगे, anti scan हो जाएगा, major malformations पता चल जाएंगी आपके 12 हफ्ते तक, 95% of your problems will be picked up. So with these words, I will ask Dr. Khurana to take over. So this is what I can give a remark, because I was given 10 minutes. I thought I must utilize them properly.
Thank you.
I'm inviting the chairpersons of the session, Dr. Raj Bokaria, ma'am, Dr. Uma Maurya,
Dr. Sangeeta is waiting. She cannot join. Dr. Umarai cannot join. They are ringing me up and they cannot join.
Okay. So I'm inviting Dr. Ashok Khurana sir, who is a legend and is teacher of teachers, to give this talk.
Doctor, आपको दोबारा कोशिश करो, public में join कर लो. ठीक है?
Sir, please.
Yeah, I think some of them have managed to join, but should we go right ahead and then they can join us during the talk? Yes.
Yeah.
Chairpersons cannot join. They are ringing me up.
Dr. Raj Bokaria has joined already.
What about Dr. Sangeeta is ringing me up?
I'll just speak to her, ma'am. I'll just speak to her.
Okay. So
yeah, Dr. Raj Bokaria is there already. Yes.
Yeah, ma'am. Dr. Raj, can you please introduce Dr. Ashok Khurana sir formally and invite him for the talk. Raj, ma'am. I think she has some technical issues, so we will give to the.
I think Dr. Khurana does not need any introduction.
Yeah.
He's one of a very dear friend of ours,
Yeah.
and not only and he's a very popular ultrasonologist in the country. So as far as these the gynecologists of City of Delhi, if they're stuck with any problem, they reach him. So I think he's the guru of gurus.
He's
That's
teacher.
the only thing I can definitely say.
Yeah.
Thank you, ma'am. That is so kind of you. And thank you, Dr. Krishna Gopal, for arranging this meeting today. It's a continuation of the marvelous partnership that the Delhi Gynecologist Forum East Delhi has with the Society of Fetal Medicine. We have a complete overlap of our memberships because both of us firmly believe that the goodness for the patient lies in speaking the same language. We realized several years ago that people who do ultrasound speak a different language. We realize that we have amongst the gynecologists and we have Greek amongst the radiologists. And then we have the practicing obstetrician who works at the grassroots level, who just realizes that there is no Hindi or English in this whole thing. And we did realize that we really must speak the same language. And I'm so pleased that we have associated so frequently to make sure that our final aim, that of giving every fetus an optimal outcome, is reached. And my congratulations to Dr. Krishna Gopal for taking the initiative in this over the years. And thank you, Dr. Sharda Jain, for always being there for us and for guiding us. We greatly appreciate your regard. We greatly appreciate your inputs. And we always look forward to your criticism, because the essence of success is a critic. And the true mark of a friendship is a critic, because then only can you improve and then only can we move ahead. And that's the essence of technology as well. So thank you very much. I will go over this talk of mine, which is on the thickened nuchal translucency. And what I thought I will do is mainly discuss the thickness from a very clinical point of view, give an overall perspective, and bring everyone up to date on what's happened in the last year or so to make sure that we are completely in sync with what is going on. And so if I may share my screen, and I do hope it shows up in the next few minutes. I think it's showing up now. Are you able to hear me, see me, and see my pointer?
Yes, sir.
Yes, wonderful. So I will discuss the nuchal translucency, and we know that this is the fluid that is normally seen at the back of the fetal neck and lies between the back of the occipital bone and the skin covering, and can be very well seen in an image like this that we take today as an anechoic area with a bright white wall at the back, which represents the skin. We also see a lot of midline structures, which we are not going to talk about today. But what we will talk about is how we moved from an image like this, which was regarded as the technical innovation of the 90s, to an image like this, which gives us more understanding, and more importantly, the clinical relevance of an image like this. And so what we will discuss is how things started and where we stand now. The first reference to the fact that the back of the neck might be relevant for us came from John Langdon down in 1862, when he described that in these babies that have a mental retardation, which he classified as idiots at that time, politically incorrect word for today, but nevertheless, apart from a flat face and a nose that was too small, he defined that the skin is deficient in elasticity, giving the impression of being too large for the body. It was not known until 100 years later that this was actually a genetic disorder, and that was trisomy 21, an extra chromosome 21, and that was described by Jerome Lejeune in 1959. Its translation into clinical practice, in antenatal practice, came much later, and that was when Beryl Benacerraf told us in 1987 that this loose skin can be seen in the mid-trimester anomaly scan at 20 weeks as a thickening of the skin at the back of the neck in an axial view of the skull that also shows us the cerebellum. So this area is what she defined as a nuchal fold, and that thickness was what she defined first. It rapidly moved on, and within 5 years, we saw that this had got translated into the first trimester already because of the great work of Kypros Nicolaides. And he was the first one to point out to us that there is edema at the back of the neck. These were the original images from his description in 1992. I know he himself would throw these images out of the window, but they had that information that there is this relatively focal hydrops at the back of the neck, and that if we look further into this, we will be able to identify babies with Down syndrome. The technique continued to refine itself until 1999, when it was announced that, look, if you measure this and combine it with two parameters in the maternal blood, the serum beta-HCG and the serum PAP-A, we will have a 90% detection rate for Down syndrome with a 5% false positive rate. And this is what we're going to discuss today. Images evolved from a crude image like this to a not so magnified image like this, but which was mid-sagittal. And this was from the original textbook from the Fetal Medicine Foundation, to an image like this, which was also in the same textbook, which showed a thickening to what we see today, which is a highly magnified image, including just the head and the neck. And this thickening at the back, when it gets thickened to a certain amount, which we'll discuss today, is what tells us that something may be wrong. Again, I emphasize something may be wrong, because the thickening could also be physiological. So after this historical perspective, we'll go through a current protocol. We'll try and understand why the NT thickens so that we can figure out what to do about it, current cutoffs for NT in terms of mathematics, what next guide, and then some carry to your clinic messages, which you can use from the coming week onwards. So by 1999, we had an excellent publication. And by the year 2002, we did realize that yes, it was being used widely in most parts of the world. And by 2005, in the United States of America as well, which then became the ultimate acceptance, because the Americans are typically the last to accept any of these advances. So there had been a gradual stream all along this also, which was in biochemistry. And although the triple test originated in the 1980s, we know we should not use it today because it gives us a detection rate of only 65%. For a test to be acceptable today, the International Society for Prenatal Diagnosis tells us that we must have at least a 75% detection rate. The quadruple test, which is done in the second trimester, matches this somewhat, but very rapidly we moved on from the quadruple test to the first trimester combined screen, which is what we just discussed, the Nuchal Translucency, along with PAPE and free beta HCG, which gives us a 90% detection rate. 9 years ago, however, we had a new technique for diagnosing aneuploidies, and that was cell-free fetal DNA, fragments from the placenta breaking off, and that free DNA circulating in the mother's circulation can be evaluated, and we can evaluate trisomy 21 with this. When this happened, it was presumed that with such an accurate test available, more than 99% detection rate, with a very, very minimal false positive rate, it was still accepted as screening, with the fact that, look, if you get screen negative, that means that this fetus is going to be normal. If you get screen positive, it could still be normal, and therefore we need invasive testing. We went ahead and said, okay, now we will stop nuchal translucency, we will stop first trimester imaging and move straight on to NIPT. We made a mistake because we suddenly realized that the detection rate of 99% can only be that accurate if the amount of circulating free fetal DNA in the mother's blood should be more than about 3 to 4%. So every DNA report now carries a fetal fraction, which tells you that in the mother's blood there is maternal DNA, free maternal DNA, and free fetal DNA. And if that amount of fetal DNA does not exceed about 4%, that report no longer holds good for the 99% plus detection rate. Yes, there are new techniques of NIPT that can be more accurate at a lower fetal fraction, but as a population screening, if we were to use it, we'd have to match at least 4% or 3.9%, as some people say that to be. There was this problem all over the world. These companies were marketing themselves directly, and we were losing control, but fortunately it got self-regulated in India very early because of the efforts of so many of us. And we said that, look, to get that fetal fraction, we have to look at the patient. She must have an appropriate maternal habitus. A heavy lady with a BMI more than 26 needs to go in late, because then her maternal fraction is higher and the fetal fraction is therefore lower. Also, to have that achievable fetal fraction, we need a certain duration of pregnancy. We need to know the number of fetuses and whether the fetus is alive or not. And if you don't have this, you cannot interpret the NT, and you cannot interpret the NIPT, and therefore you're lost completely. And so automatically then we had to do a scan to date a pregnancy and to confirm number and viability. And then we said, look, if you're doing that, then we may as well look at everything, because anomalies are important, and we can identify so many of them by this stage, about 60% that we can identify at this stage compared to about 90% in the second trimester scan. We can do additional evaluation for aneuploidies more than the NT and include nasal bone, ductus venosus, and tricuspid regurgitation. And of course, screen for preeclampsia, growth restriction, and exclude maternal pelvic pathology. And so the NT scan came back, and that's where we stand today, that the NT scan, along with biochemistry, the so-called first trimester combined test, is there to stay as our mainstay. Second trimester screening is secondary screening, either for patients who report late or for patients who don't want invasive testing to take place in the first trimester, and therefore they would need an assessment by about 16 weeks. And there comes the role of the quadruple test. So we had this wonderful paper last year that finally summed up what I've just told you, and it clearly said that we must acknowledge that there still is a role for the nuchal translucency measurement in this changing paradigm, because if we were to look at other disorders, NIPT is only going to tell us chromosomal abnormalities, but if I want to look at other disorders such as single gene disorders, submicroscopic disorders of the genes, and structural abnormalities, I will be missing a lot of these if I don't do an NT scan. I would only just about pick up trisomy 21 and nothing else. And so we have this role which we will discuss today in the perspective of an abnormal NT. The first test that we offer when we see a thick nuchal translucency is invasive testing, because it is the most accurate. We never used to offer this before, A, because we didn't have expertise, and B, because of a miscarriage rate. But we did realize again in the second half of last year, from a paper by Laurent Salomon in the White Journal, that the risk of miscarriage from either an amniocentesis or CVS is very, very small and equal to the miscarriage rate in that person because of other pathology that she might have, such as Mullerian abnormality, such as, for instance, a septate uterus, or fibroids, or a previous miscarriage, or some other disorder in her basic system that she's prone to miscarriages. And this miscarriage rate in experienced hands will be the same. And therefore, we must offer invasive testing to everybody. And this is what was said. This paper was re-emphasized 2 months ago by another study which says that now we have a better way of actually calculating the miscarriage rate. And this is now available as a free download from the White Journal website, Ultrasound Obstetrics and Gynecology 2020. And it clearly says that, look, you can calculate this miscarriage rate, tell the patient that, yes, this is the miscarriage rate, and would she then, for a thick nuchal translucency, like invasive testing, or would she like non-invasive testing, or would she like to think over it, add all the additional features of an ultrasound scan, such as ductus venosus, tricuspid regurgitation, and come back for a review at 16 weeks, and then we can decide for an amniocentesis. So these are the various things that we will discuss as we go along. Because we have realized that looking at a thick translucency makes sense. The question is, when do we call a nuchal translucency thick? We now express the nuchal translucency as centiles. That means if we were to arrange in all fetuses, the nuchal translucency from 0 to 100, we would find that on the thicker end, there would be more abnormalities. If we were to look at anything that was less than the 95th centile, chromosomal defects, the risk of fetal demise in utero or stillbirth, and the risk of fetal major abnormalities is very minimal. And most of these babies would be alive and well at the end of the pregnancy. Between the 95th and the 99th centile, there would be a 3.7% incidence of chromosomal defects, and we shouldn't be able to miss out on this because these are important. The risk of fetal demise, we would still be able to identify with other tests, and fetal abnormalities, we will be able to identify in the second trimester. But this business of picking up abnormalities where the nuchal translucency will not translate to a thick nuchal skin fold at the time of the anomaly scan is important, because most of the nuchal translucencies will disappear after 14 weeks, and we have to catch them in the first trimester. And therefore, then we started looking carefully at the 95th to the 99th centile. The 99th centile translates to approximately 3.5 millimeters at its uppermost. And therefore, we used to use that as a cutoff. And the thicker the nuchal translucency got, the more we got chromosomal defects, the more the risk of intrauterine fetal demise, and the higher the risk of abnormalities. But do remember that even with a nuchal translucency of 6.5 millimeters, almost 3 times the usual size, can still result in a healthy individual 15% of the times. 1 out of every 6 will be a normal fetus, and therefore we should not ever terminate on the basis of a test like this. This is a screening test. It tells you there may be trouble. It does not mean that there is trouble. And then we have to figure it out. We'll come a little more to these cutoffs and see whether we should use centiles, whether we should use 2.5 millimeters, 3 millimeters, or 3.5 millimeters as we go along. And let's look at a few other things before that. The first thing we realized is that nuchal translucency thickness does not just mean trisomy 21. It means a whole lot of other conditions as well, and many of these are genetic. The big bunch of genetic syndromes includes Noonan syndrome, and then not so unusual syndromes also like Pina-Shokir, Cornelia de Long, spinal muscular atrophy, alpha thalassemia, and Zellweger, to say a few, also Appert's. So these are fairly common. People who work with high-risk pregnancies do get to see these, and therefore we have to be sensible about realizing that we can't use 3.5 as a cutoff. We have to use something between the 95th and the 99th centile, and let's see how we come to that figure. The other thing that we have expanded our mind on is that the thick nuchal translucency, apart from chromosomal abnormalities, is also a great marker for cardiovascular defects. And the higher the NT, the higher the chance of major fetal abnormalities and the higher the chance of cardiac defects. Also pulmonary defects, skeletal dysplasias, congenital infections, including cytomegalovirus and rubella, metabolic derangements, and hematological disorders, especially beta thalassemia. Remember also that apart from this, any abnormality where the fetus does not move can also give us trouble. And that is where we have to be careful, because again, we have thick nuchal translucency. So when we do our scan, we look not only at structure, but we look for movement as well, in addition to a thick nuchal translucency. Now, it's important to realize that there is this variety of things behind a thick nuchal translucency, not just trisomy 21. Even in trisomy 21, there are various causes of the pathophysiology. One, of course, is that the degree of extracellular matrix goes way below the skin. Vessels can get congested, and we have, as seen on these micrographs, a physiological or pathological narrowing of the aortic isthmus, which causes blood to dam up in the heart and a technical congestive heart failure. So the actual nuchal translucency is a consequence of cardiac failure as a result of structural abnormalities. Venous congestion due to constriction of the fetal body in amnion rupture is one possibility, or superior mediastinal compression as in a large diaphragmatic hernia. The narrow chest and skeletal dysplasia, altered composition of the extracellular matrix, as we find in fetuses with skeletal dysplasia, and abnormal or delayed development of the lymphatic system, such as we find in Down syndrome, a failure of lymphatic drainage because impaired fetal movements like I described, fetal anemia and hypoproteinemia, and of course congenital infections acting through anemia or cardiac dysfunction. So because of this, we have this wide range of causes, but this has a very important implication, and that is that if you don't find trisomy 21, a thick nuchal translucency can mean a whole lot of other disorders, and these need to be assessed and addressed. And we will discuss that. We do realize that if the conventional karyotyping is normal, increased NT is a predictive value of adverse pregnancy outcomes because it is associated with all these conditions, and we have to be careful about it. In addition to the chance of euploidy becoming less and less as the nuchal translucency thickens, we find the risks of intrauterine death increase and severe defects increase to almost 50% by the time we reach 8 millimeters. But we do understand that the thick nuchal translucency is a pathophysiological diagnosis and not the name of a disease. Consequently, it is a label to investigate and not a label to terminate. If a fetus with a thick nuchal translucency does not have Down syndrome on genetic testing, which is QFPCR or FISH or conventional karyotype, it needs further evaluation to exclude a large number of conditions, including genetic conditions, and these will show up on a microarray or an exome sequencing. Also, that a negative screen on NIPT will reasonably exclude trisomy 21, but it will miss the rest of all these conditions that we have described if we don't do a decent nuchal translucency scan. And therefore, the nuchal translucency scan is here to stay, and the thick nuchal translucency needs adequate respect in our clinical evaluation and lab evaluation. We've known for many years now that second trimester screening is not as good as first trimester, that maternal age alone will identify only 30% of Down syndrome because 70% are born to mothers who are less than 35, and that's because they're more reproductive. That maternal age plus nuchal translucency is not so great. It's only 75 to 80%. Biochemistry is worse, only 60 to 70%, even in the first trimester. But if you were to combine the nuchal translucency with age, free beta HCG and PAP-A, the so-called combined test, like I mentioned several times, you get an almost 85 to 95% detection rate. If I combine these with additional parameters, such as the nasal bone or tricuspid flow or ductus venosus flow, I reach a detection rate of 96%, and my false positive rate, which is what bothers us the most, because patient says the test was wrong, goes down to 2.5%. And therefore, ideally speaking, a good ultrasound scan should include all or some of these additional parameters for Down syndrome screening as well. When we do this whole story, we always combine not only crown rump length, nuchal translucency, PAP-A, and free beta HCG, but also the background of maternal weight, ethnicity, IVF or no IVF, the number of fetuses, diabetes mellitus, and smoking when we make our risk calculations. And the parameters we use in addition to nuchal translucency, like I said before, is ductus venosus showing reduced forward flow or reverse flow and significant tricuspid regurgitation. We used to use the facial angle, we no longer use it. We used to use the hepatic artery, we don't use it because it gives the same information as the ductus venosus. And so we stick to this for now. Remember that size matters. And the reason it matters is that when we look at nuchal translucency today, we realize that the thick nuchal translucency is often associated with structural abnormalities, and structure is not so well seen at 11 weeks plus as it is seen at 12 weeks plus. And therefore, we prefer seeing fetuses for everything at about 12 weeks plus, when the crown rump length goes up to about 64 millimeters. I do agree that PAP-A, where we look for a reduced level of PAP-A, is best at 10 weeks and not so good at 13 weeks. Beta HCG is about the same from 10 to 13 weeks. But if I do see even at 12 weeks, it's not so bad. So for patient convenience, we could combine the biochemistry and the ultrasound in a single sitting. But ideally speaking, we should be able to pull our patients in at 10 weeks for a biochemistry. That's not really practical. We know how difficult it is to make patients do things like this. And therefore, we do understand that we have to be sensible about this. I'm just trying to get back into my program, which I seem to have missed out on. One moment. Are you able to hear me? Are you able to see me or hear me?
Yes, sir.
You are. And my screen is full.
Yes, sir. Yes, sir.
Clearly visible.
Because I seem to have lost my screen, but I will try and get back onto it as fast as I can. Yeah, there we are. Yes. So the ideal thing is to try and get the patient in at 10 weeks for biochemistry, 12 weeks for ultrasound, but that's not always possible. So we'll try and get them at about 12 to 13 weeks and preferably not at 11 weeks. Now, it's as important to measure the crown rump length as the nuchal translucency. And the figure we use here is between 45 and 84 millimeters of crown rump length, and it should be properly done. You read it off from any chart, and all these charts are just about the same. Can we start measuring this earlier? There are some nice papers, and it is useful because the whole idea of early diagnosis is truly early diagnosis. And if we can start looking at these abnormalities earlier, the patient happens to come to us, say for bleeding in pregnancy or pain, or just happens to have a scan because we were doing a follow-up for IVF, then we'll say, okay, Can we pick it up at, say, 28 millimeters? Yes. About 6 years ago, we got this paper with very good descriptions of nuchal translucency from 28 millimeters crown rump length, and this is useful. We may not be able to combine it with biochemistry, but by itself, a great way to stratify patients who need to come back definitely by 12 weeks to see what should be done. They should not miss their first trimester scan. The crown rump length should be done in the proper way, and there's not enough time today to describe that, but do remember that we have to become familiar with this mid-sagittal picture with the baby occupying most of the screen and enough fluid between the chin and the chest, which tells us that it's not overextended or overflexed, because then the nuchal translucency can also be altered. The nuchal translucency itself is seen with only the head and the upper thorax. And you must be true mid-sagittal, which means no zygoma seen between the nasal bone and the palate. That there should be fluid between the chin and the chest. And in the same image, you should be able to see the midbrain, the future fourth ventricle, which we call the intracranial translucency, the future, the cisterna magna here, and the nuchal translucency at the back. And the zooming should be right and the gain should be turned down so that the white is white and the black is black. It's very important for clinicians who use this information to realize that they must have information that looks like this, not just small fetus, big screen, and any black area measured as the nuchal translucency. That is important. Then we must look at markers also. They must be plus markers, not cross markers. And the horizontal line of the plus must overlap the white so that we know exactly what we're measuring. And again, from front to back, no zygoma between the nose and the palate, no white line between this area. This area should be hypoechoic or dark, like you see it here. And that's the correct nuchal translucency and the correct way to do it. There can sometimes be a cord around, and that can cause a minimal thickening below the cord in the neck area. It's not dangerous for the cord to be around at this stage. We measure above, we measure below, and we take a mean of that so that we don't exaggerate the thickness of the nuchal translucency. We then read it off from charts, and the charts are shown here. This is the old chart that we used to use from Sono World, and now we have Nicolaitis' chart as well. And sorry, this is the Sono World, and this is Nicolaitis' chart, and we read it off, and it tells us exactly which centile, and we start making a fuss at about the 95th centile onwards. Do remember that we pointed out from our center in 2012 that the Indian translucency is generally thinner than other translucencies in continental Europe, for instance. In Northern Europe, again, we have thinner nuchal translucencies. In Thailand, we have thinner nuchal translucencies. But for some reason, for the sake of uniformity, we follow what the Fetal Medicine Foundation tells us. But we now have more papers like this over the last 8 years that tell us that perhaps we should not neglect anything beyond the 95th centile and not wait for the 3.5 in our Indian patients. We should go by the centiles and use the 95th centile as a cutoff. Remember that all these should be done by a qualified person, an experienced person who gets his results audited, and therefore that is important. You should know the person who's doing the scans, otherwise you may not find that the information is reliable. We have at the Society of Fetal Medicine tried to promote the familiarity with the normal nuchal translucency section. And for those of you who want this paperweight in your office just as a ready reference, please inform Dr. Krishna Gopal, and he will arrange to have these delivered from the company that is supporting us in this endeavor. So that whenever you see an image, you can compare it with this and take it on from that particular point of view. That's the best way to do it. And of course, please do remember that we are at the Society of Fetal Medicine trying to start our own first trimester quality control program virtually, because we've not been able to meet on site for a long time. We were taking this training program all over. Our president, Dr. TLN Praveen, is now working on the virtual program to make sure we can educate as many more people as we can and get their results and their submissions online so that we can certify them and look at their auditing accordingly. We don't like the nuchal translucencies to be assessed too low or too high. They should occupy this normal graph like in this one. This is under assessment, this is over assessment. Now, what do we do with this information? Well, never use nuchal translucency alone. We never use age alone. Yes, crown rump length and NIPT is fine, but it misses the advantages that I've already described, plus it's expensive. If we use only age, crown rump length, and NT, you need a lot of skill. And like I said, it only gives you about 85 to 90%. Age plus biochemistry is not acceptable. Combined test is the best population method. Additional markers add things, but they require time and skill. That may not be possible at a busy hospital level where you don't have professional expertise, or you don't have good enough machines, or you have an overload of patients. And so every institution should identify that, look, this is the way we're looking at this, and this is how much we can do, and this is how much we cannot do. And it should be mentioned in the report that this was done on this basis and didn't include biochemistry, or included only the NT and didn't include everything else. That would be an honest report, and clinicians should know whether only the NT is being used, or it's NT plus biochemistry, or it's NT plus additional ultrasound plus biochemistry. The biochemistry has also been improved by some people by adding on a T2 quadruple test. This is not routinely required. It's only required if your NT is unreliable, or patients who don't want a testing by invasive methods in the first trimester. You have a T1 quad, where PLGF has been added on for preeclampsia, of course, and alpha-fetoprotein for increasing the chances of locating a neural tube defect in the first trimester, and a penta, where they've added a dimeric inhibin A that takes the detection rate to almost 88% plus and brings down the false positive rate to about 1.2%. So this is constantly improving the biochemistry, but the essential thing remains a combined test, and you can improve it in whichever way you want. Because if you have just a thick nuchal translucency and you haven't assessed it correctly, it can be better assessed by combining it rather than by itself alone, so that you reduce your number of false positives. You then divide your patients into risk groups, and irrespective of the nuchal translucency, if you have a high risk of more than 1 in 10, you always encourage invasive testing in your language, although you're not supposed to be directive. If it's greater than 1 in 50, you offer them the alternatives of NIPT or invasive testing. If the risk is less than 1 in 1,000, such as 1 in 1,200 or 1 in 10,000 or 1 in 20,000, all they need is a routine anomaly scan at 18 to 20 weeks. However, if the figure is somewhere between 50 and 999, these patients fall into an intermediate risk and need further assessment, because there's a fair number of abnormal NTs and abnormal fetuses in this group. In that case, we definitely encourage nasal bone evaluation, ductus venosus and tricuspid regurgitation, recalculate the risk, and then add NIPT in case the patient wants it, or in case the patient opts for it, give them invasive testing. So we must use a cafeteria approach and say, okay, these are the possibilities. This is what you can do. This is what you can choose. What would you choose? But typically, the higher the risk, the more we encourage invasive testing. We do have some people using 200 as a cutoff instead of 50. Some people use 300. Even Kypros Nicolaides changes these every year. The idea is to increase the detection rate and reduce the false positive rate. But do remember, combining the thick nuchal translucency with the other things definitely reduces this. So this is what I just told you about, the intermediate risk, shifting to an NIPT and then see what the results are. Do remember that a lot of us believe that we might miss a few things in case we have normal biochemistry. And therefore, some of us do believe that the thick nuchal translucency, don't wait to add on the rest of the parameters, skip the screening and encourage the invasive testing straight away. But do remember, again, like I said, a cafeteria approach. Let the patient decide, and you have to counsel the mother, the couple, the family, and the community if necessary. If you don't have the time, a junior can do it. If they don't have the time, a counselor can do it. Counselors are now available. Good counselors are available, and we can use their facility. And then we go ahead and make a decision. Now, coming back to this question on 3.5, we've always used as a cutoff for invasive testing. Should we shift this to 3 to 3.4? And the answer seems to be yes. That between 3 and 3.4 nuchal translucency, irrespective of gestational age, we do have a high incidence of finding problems, and we need to address those. But do we bring it down to this paper, which came out last year, which says, look, let's bring it down to 2.5? Perhaps yes. And this is where we then go back to our old definition, that rather than using an absolute cutoff of 2.5 or 3 or 3.5, use the centile cutoff. anything above the 95th centile, encourage invasive testing or give the patient what possibility she has, such as in case she wants to skip invasive testing, we can do a little more biochemistry, we can do an NIPT, or we can review at 16 weeks with an ultrasound and more biochemistry and then decide what she wants to do. But let's use for now the method of actually using the 95th centile as a cutoff for what we should be doing. Remember also that we no longer just depend on a conventional karyotype when we're looking at a thick nuchal translucency. Particularly at the higher ones, we realize that a microarray gives us more results in terms of abnormalities than a karyotype. We add on almost 6% in case of an increased NT, and in case you find a fetal defect, then again another 6%. In case of multiple defects, the detection rate goes up by about 9%, and an exome sequencing can enhance the yield of an abnormal genetics from almost 6% in some cases additional to another 80%. Therefore, the story now doesn't stop at QFPCR or FISH for trisomy 21. It doesn't stop at conventional karyotype. From QFPCR for rapid diagnosis, we move to a microarray for more genetic diagnosis. And if that comes correct, we still need to counsel our patients further. And let's see where that step takes us. We do realize that if we find abnormalities at the 16-week scan, we do need invasive testing. If we find a persistent thick nuchal translucency seen as a thick nuchal fold at 16 weeks, there's a high chance of Noonan's, and therefore we go beyond CMA or conventional karyotype and add on sequencing for Noonan's, for which you have to speak to the lab. The lab always keeps the DNA they got from a CMA. So you don't have to pay additional for DNA storage. Tell them to store the sample and that you might need it at 16 weeks, particularly if edema persists or in case you find that additional abnormalities come up. So essentially a QFPCR or FISH to exclude a Down syndrome and also 13 and 18. Then review at 16 weeks. If you find thick nuchal, Noonan's. If you don't find thick nuchal, look for other structural abnormalities. And then you might do a wider sequencing. And then again, you have to work with a geneticist. Then the story doesn't stop there. You call them back for your anomaly scan at 20 weeks, include a detailed cardiac evaluation, which we call a fetal echocardiography, and then tell them that, look, things seem to be fine. Even at this stage, sometimes you might add on an exome sequencing. And then, of course, a growth scan at 28 weeks and a detailed examination after birth. So this counseling has to go there, that there are no guarantees. And that should be part of the counseling because we do have this high incidence of cardiac abnormalities with the thick nuchal translucency. The thicker the nuchal translucency, the higher the chance of a cardiac abnormality. As you see here, we find tricuspid regurgitation, reduced forward flow in the ductus venosus, and you find one side of the heart just not filling and a massive regurgitation across the tricuspid valve. So there, of course, you have a full diagnosis, but if you don't, you call them back at 16 weeks and then take a look. Remember also that there is a higher risk of neurodevelopmental disorders with a thick nuchal translucency, and this includes intellectual disability and autism spectrum disorders. And even after your 22 weeks review of anomalies and review of fetal echocardiography, you must counsel your patients. If they opt for stopping that pregnancy, that is their choice. But it is our duty to tell them that, look, there is this slightly higher risk of these two things. It really does not justify a termination because it's very close to the figure that we have of these abnormalities within the general population. But it's a reality and we have to counsel our patients accordingly. So where do we stand today? Let me conclude with these two slides. In the economically privileged patient, the first trimester screening should be an 11 to 14 weeks complete assessment, including abnormalities of structure and preeclampsia. First trimester combined screen with PLGF and NIPT. And in patients who can't afford that or the ones who are undergoing population screening, a first trimester combined screen, which is NT, PAPE, and beta HCG, of course, quality controlled. An institutional protocol can be put in place for centers that have either economic limitations or technical limitations or staff not enough. What do we do with this information of the thick nuchal translucency? We have to ideally follow it up with invasive testing. a rapid diagnosis of trisomy 21, 13 and 18 by FISH or QFPCR, then a microarray to give you a better genetic diagnosis. Then, of course, if you have only NIPT, you miss a lot. Persistent abnormalities or new abnormalities, you might want to look at single gene defects or exome sequencing. And this must be considered even if the microarray is normal, and we typically take this decision at 16 weeks. Then we call them back at 18 to 20 weeks and then at 22 to 24 weeks to do their final anatomy scan. And then we seem to be almost equal, except for that little bit of a higher risk of neuro disabilities. The story, of course, has just begun, and I promise we will repeat some of these factors at the time of our discussion on the panel. Thank you so much for your attention so far.
Thank you. Thank you, Dr. Ashok Khurana, for such an elaborative talk, so simplified, and so many caring home messages for every obstetrician. And I think you have highlighted very well about the increased thickness of nuchal translucency is not an indication for termination. It is an indication for further workup and further counseling with the parents. And you have highlighted and impressed very well how nuchal translucency has so many implications. It not only rule out the Down syndrome, but it has other implication of various chromosomal defects, cardiac defect, why it occurs, what the next step one clinician has to do. I think you have made every obstetrician very intelligent, and they are going to take and utilize these all tips what you have given practically in their daily practice. Thank you, Dr. Ashok Khurana, once again, and I thank Dr. Krishna Gopal and the East Delhi Gynae Forum and Ghaziabad Forum to invite me as a chairperson. If anyone wants and have any question, they are free.
Ma'am, we will take questions in the last after our second sessions. Our second session is a panel discussion, and that is about different cases having various outcomes of abnormal NT. And here we have a list of great panelists on the board. Dr. Poonam Goyal, who is a senior consultant in Vaishali Max and her own hospital. Dr. Sucharita Jain, she is a well-known radiologist in East Delhi. Dr. Jyoti Bhaskar ma'am, who is a senior consultant in Vaishali Max and Apollo Cradle. Dr. Jyoti Agarwal ma'am, who is a senior consultant with Life Care Hospital, and Dr. Shushma Jindal ma'am, who is well known in IVF circle, but whatever she does the perfection. She does a lot of good scans as well. So welcome all of you to our panel. Sir, please take over.
Thank you, Krishna. That's very kind of you. I see Dr. Umar Rai has joined us as well, and we'd greatly appreciate inputs on this as we go along. I have a dream team as a panel, and we're going to discuss 3 cases. The first one is a little long, the second one is medium long, and the third one is short. And we want to actually highlight not cases which are routine from a diagnosis point of view, but cases which are like off the street, things that hit you every day, and how you and me in the real world don't handle the ethereal situation of what I've just spoken about. That is Europe. That is something we would dream about. That is something we aim for. But basically, you and me are faced with the peculiarity that only you and me can understand. And I'll try and bring that out. And I'm lucky that I have people who have their feet on the ground and their dreams on the stars and their eyes on the stars. And we will go ahead with this. Thank you, Krishna, for putting such a wonderful panel together. My welcome to everybody. And the audience can put in their questions at any time, and we will take them at the end, and we have plenty of time today. So our first case is a 23-year-old primee, and she presents for the first scan at 12 weeks and 1 day of gestation. And this is her first ultrasound. It reveals a single live fetus with a crown rump length of 64 millimeters and a nuchal translucency of 3.4. So Dr. Sucharita Jain, is this normal? You'll have to unmute yourself.
Is unmoved.
Yes.
No, this nuchal translucency for this particular CRL is corresponding to almost 99th percentile. So
Yeah.
it is not normal unless proved that we have to investigate the pregnancy further by various methods to prove that it is not abnormal. The baby is not abnormal, but as of now, we have to follow it up.
Wonderful. Thank you for that nice, neat, clean input. And this is what the panel will be telling you about. Some of it will be a repetition of what I've already spoken, but I know that you and me believe that the more we have repetition, the better we learn and the more we think. So we move on to our second question. This is for Dr. Sushma Jindal. What is the best window for evaluation of the aneuploidies? 11 to 14 weeks, 16 weeks, or 18 to 20 weeks?
Evaluation means to identify the probable chance of having aneuploidy with screening tests, and in case she falls into a high-risk category, then advise a diagnostic invasive test. So the choice of test will depend on the test availability, the gestational age of the patient, number of the fetuses, her obstetric history, the family history, and the sensitivity of the test, the results to be available in a very short period, desire for her early test results, and the availability of the invasive test in case it is needed. So the window period between 11 to 14 weeks, that is the ideal. When the CRL is between 45 to 84 millimeter, a combined test done in this window, that is inclusive of maternal age, anti and serum biochemistry inclusive of PAPA and beta HCG, it gives a detection rate of approx 85 to 95% with a false positive rate of 5% only. And also OAPR, that is also having an affected baby after a positive test results of this first trimester combined screen that done between this window is about 1 in 22 with a false positive rate of 5%. That is quite acceptable. And also doing an ultrasound during this period, it helps us in confirming the viability as well as the number of the fetuses to establish gestational age and to evaluate gross fetal anatomy and the risk of aneuploidy. So my recommendation would be a window period of 11 to 14 weeks.
Thank you. Thank you very much. And we move on to our next question, and that is for Dr. Poonam Goyal.
Yes.
Why is it important to assess for aneuploidies?
Assessment of aneuploidy is very important part of antenatal care of all patients. Aneuploidies are actually the abnormality of numbers in the chromosomes, that is normal 46, any deviation from that. If there is some extra or some less, or there is aneuploidy in germline, it most of the times results in miscarriages. But the things are not same with trisomy 21, 13 and 18. With 13 and 18, the survival is short, but with 21, the survival is not that short, and the baby born is with Down syndrome. The baby has mental retardation and other physical challenges also. And we don't have any cure for that. We may have cure for many diseases at present, but at present we cannot change the chromosomes of the cells, so the baby has to go like that only. It is a financial burden on the family, on the society as well. So it is best to have a proper diagnosis by the end of the first trimester, whether the baby is Downs or not, and if there is any chance of having aneuploidy in the baby, the couple has always option for opting MTP, and this is the best time with least morbidity to the mother for abortion. So I think we should have assessment for aneuploidies in all the pregnancies.
Thank you so much. There are some people who say that we're using very harsh words when we talk about financial burden on families, etc. And they said, look, it's a divine
Yes.
responsibility.
Yes,
But we
it's
must understand,
ultimately patients or the couple's decision to opt for
yes,
MTP. Or
and they, a lot of people who think they're politically correct, some intellectuals, some NGOs say we should use words like a burden. But the fact is that if we don't accept the way our patients think about it, especially in our part of the world or in the developing world, we have to use words like retardation. We have to use words like baby can die. We have to use words like there is a burden, which is a financial burden, a social burden, social responsibility, etc., etc. So would you agree with me that these are correct words to use, even though they may not be politically correct?
I don't. It all depends upon how you are counseling
Yes,
and which type of couple you are dealing with. Not
yes,
all are that delicate kind of things where you have to use the words like physically challenged, mentally challenged. I
yes.
don't think for all you need to use those words, but
No, I think we need
definitely
to
they
be
are better
direct.
words.
Yes, we need to be very direct. I would
Yes,
fully agree with you that when we skirt the issue, we just seem to miss this point. And we
yes,
have to hit them straight with it because they are the ones who have to face life. For us, it's another patient, but they have to face
they
this
have to face.
day in and day out. And yes, some families handle it very well, but most families are not able to handle it very well. Thank you so much for that straightforward answer. Uh, uh, what are the pregnancies that should be offered screening for aneuploidies? This is for Dr. Jyoti Agarwal.
Yes, sir. In my opinion, all pregnancies should be uniformly offered the screening test because it's a screening test and the correlation between the age and the chromosomal problem, if we just go by this thing, we'll be missing out many more aneuploidies. So it should be uniformly offered to all. The screening test should be uniformly offered.
Wonderful. So universal screening. Excellent. Dr. Krishna Gopal, what is the difference between a screening test and a diagnostic test? And should all pregnancies be given an option of direct invasive testing?
I will take the second part first, because though we latest paper suggests that there is hardly any risk, negligible risk procedure related, but still these tests are costly and we cannot afford to offer it to everybody, even in the most developed country, most economically viable country. So we have to choose a test that divide the whole of the population between two cohorts, two groups, a high risk group and a low risk group, where high risk group only need this invasive testing and low risk group should assure that they should continue the uh, pregnancy. So that is why so screening tests are meant to actually divide the whole of the population into two risk group, that is the high risk group and the low risk group.
Wonderful. So it's a balance between economics, logistics, and of course, patients have the option of jumping from one to the other. You could have a low risk patient who would say, no, I have a brother with Down syndrome. I want invasive testing. So that we always keep an open mind. Would you agree with me there, Krishna?
Yes.
That any patient can jump over to the other side and say, look, I want invasive testing, and that's fine. And we say, yes, that's perfectly acceptable.
Convinced about this, then we should counsel the patient in detail and then should give the option.
Wonderful. Then we have a question for Dr. Jyoti Bhaskar, and that is, what are the components of pre-test counseling before our 11 to 14 weeks evaluation?
Thank you so much, sir. It's always a pleasure to be in your panel. It's always a great learning process. So what I would like to say over here is that these tests, we just can't write them on the paper. Many times as obstetricians, we just put, you go and get the test done. It requires a decent time to be spent with the patient where we tend to explain to them certain points which I feel in my practice I do. First of all, why are we doing this test? And that is, as Dr. Poonam answered, we have to tell them that we're doing it to detect the aneuploidy. Second thing we need to tell them, it is a screening test. It's not a confirmatory test, and this we need to underline it again. Third, we need to tell them that what test would be best for them. For that, we already have taken a history, we have taken the age, the ethnicity, the IVF, everything. Based on that, what would be the best test that they have? Tell them the positivities, that's the sensitivity of the test, as well as the false positive test. And I think at this time when we were discussing, I think they should be given the options of invasive as well as the combined test, and told them the risks and the benefits of these tests. Then we also need to tell them that when they are going to get the result of the test, how they will get the result. The time is very important for the patient and how we would have conveyed these results. And the last thing I think that's very important is to tell them that what is the possibility of the results, if it is positive or if it is negative, how we are going to move ahead. So if you take all the things together, I think it takes a good 20 to 30 minutes to counsel our patient, and this is the time we should spend with them before we order or write these tests.
Correct.
Wonderful.
Sir, here I would like to ask, should we take a written consent prior? What do you suggest?
Dr. Jyoti Bhaskar, what do you think? Should we have an informed consent, or the fact that they've received this information and have been explained it, or do you think it's enough to mention on your OPD card that the patient has been adequately counseled?
Yeah, I think I would say that verbal consent and mentioning on the particular paper that the patient has been counseled, patient has accepted or denied getting it done. And further, when the testing is done, I'm sure we are doing the whole procedure at that particular time.
This is so wonderful. And may I please request you to put these down on a simple piece of card and share it with Krishna so that he can then put it all together, and we will circulate this as a Society of Fetal Medicine guideline. That these are the components, that look, this is a ready reference and this is what we should be doing. Please try and cover these points. I think if we have it lying on everybody's table, along with a nice image of our Nuchal Translucency, Krishna, would you take this on as a task for us? Because I've never seen anybody put it so concisely and beautifully. Thank you so much for that answer. We move to our next question, and that is what are the generally recommended components of screening for aneuploidies in the first trimester? And this is for Dr. Sucharita Jain. Would you suggest just NT, other markers as well, complete anatomical evaluation, biochemistry, the combined ultrasound and biochemistry? And again, could you please repeat for us, what is the combined test? And we want you to unmute yourself, of course. Yes, thank you. Yes.
So generally recommended components of screening will be, of course, major part comes from this NT ultrasound scanning, which will not only include the NT part, but also include total anatomic evaluation also, because there are so many structural abnormalities that we are picking at this time, along with the other markers, if we feel that they are needed, like nasal bone, which we do it in a mandatory manner, but we may include ductus venosa and tricuspid regurgitation, etc. And along with that biochemistry also has to be added. This is what you suggested as a population screening. It's highly recommended that this much at least we are doing. And if economy is not an issue, then of course we can go ahead with further screening with biochemistry for preeclampsia, etc. also. And combined test includes this ultrasound evaluation along with the biochemistry. An advantage of combining ultrasound and biochemistry is that biochemistry in isolation can only diagnose, along with maternal age, can diagnose only up to 70% people abnormalities, ditto with ultrasound. But when they are combined, the diagnostic test, it becomes positive till 92 to 93% babies are detected. So it's very important that we combine at least these basic things.
Thank you so much for reiterating all that. We move to our next question. And this question is for Dr. Poonam Goyal. What are the first trimester quadruple test and first trimester penta tests? Could you repeat what we had just heard a little while ago? And why have screening tests evolved over the years?
First trimester quadruple test, it includes our standard dual marker test, that is PAP-A plus free beta HCG. And with that, we do PLGF plus alpha fetoproteins. PLGF is mainly for the placental function. With the levels of PLGF, we can predict that whether this lady will have preeclampsia in a future part of her current pregnancy. And with alpha fetoproteins, the sensitivity of the detection of neural tube defects and defects like omphalocele, etc., is increased, because sometimes very subtle open neural tube defects are not picked up with the low resolution machines which are routinely used in our many of the centers. So the detection rate becomes better with adding alpha fetoproteins. And the first trimester pentamarker is the combined screen that we do for the routine general population, plus moving with PLGF plus alpha fetoproteins and plus adding DIA, that is dimeric inhibin A. This also tells us about the placental function. This test is more sensitive. Detection rate is around 98%, and the false positive rate is less, that is around 2.5%, which is 5% with our other routine tests. But if the cost is not in question and we are only for the detection of trisomy 21, NIPT is any day better than pentamarker, but the pentamarker also tells us about the placental function. Now, the other part of the question, why have screening tests evolved over the years? Screening tests have evolved over time in our quest to catch the better diagnostic rates at the earliest part of the pregnancy, so that we can deal with the abnormal pregnancies at the right time. If we only use age, the detection rate was long back in 1960s was only 30%, and from that we have moved on to alpha fetoproteins, then including anti, then doing combined screening tests, which is 85 to 95% diagnostic, as Dr. Sushma Jindal has just told, with 5% false positive test. And when we are doing other markers on ultrasound, then the detection rate is definitely better, that is from 93 to 96%. But the standard of those detection or those ultrasound markers should be maintained. Otherwise, there is no use of adding all those markers, and the detection rate will definitely not improve. So the standard of those should be maintained if we are adding a DVTR and nasal bone with anti. But we must understand, with all these tests which we are doing these days, we always have few limitations with all these tests. And I feel that the genetic counseling is becoming complex day by day with all these tests and everything. So we have to be very careful while we are dealing with the patient to avoid litigation mainly. That is the problem.
Yes. Thank you. That was so beautifully put. I need now my next question, and that is for Jyoti Agarwal. Doctor, if this were an IVF pregnancy with a donor egg, how would screening be different?
If this was an IVF pregnancy with donor egg, two things need to be remembered. Two things are to be noted. First, the dating is to be done from the date of embryo transfer rather than the LMP. And the second thing is about the donor egg. Here, when we are giving the information, besides NT, NB, and the biochemistry, we need to put the donor's age instead of the mother's age. These two things, if we remember, we'll get the correct report.
Thank you. That is so neat and clear. And next question, this is Dr. Sushma Jindal. If a patient refuses screening for aneuploidies, how do you document this in the clinical records?
Although our counseling, whether it's pre-test or post-test, it has to be non-directive, meaning thereby the patient has her own right to decide whether she wants to follow our advice for aneuploidy screening or not. So in that case, she can very well refuse for undergoing aneuploidy screening. In that case, we should have in writing the details, what we have told to her until now, like her ID, her name, her age, and along with the UHID of the clinic, the date that she visits to us for the first time, write down that she has been given adequate information on the advantages, the disadvantages, the detection rates, and the false positive rates of the test advised to her, the limitations, the risk and the benefits of each test, and also she has been given enough information about the cost of the test and reporting time of the tests. And she has got a chance, there is a chance of aneuploidy for NT is increased. So she must be advised for the aneuploidy screening because there are associated chances of having cardiac or structural, pulmonary, skeletal, and genetic disorders along with. A word of caution along with, when she is having raised NT, there are chances there may be a fetal demise in utero, either in the form of miscarriage, because we have seen then in trisomy 21, approx 30% of the fetuses, and in trisomy 18 and 13, approx 80% of the fetuses die in utero between 12 to 40 weeks. So in case she doesn't want to get her screen for the aneuploidy status, then her reason for declining the screening should also be documented. Take in writing that she understands the information given to her in her plain language that she understands. And at the end, keeping a soft corner, ensure her that further consultation and support will be available to her to decide whether she wants to continue or terminate the pregnancy. We must not forget to keep one copy duly signed by the patient with us.
Thank you. We move on to our next question, and this is for Dr. Krishna Gopal. What do you think is the ultrasound features which would constitute a complete ultrasound assessment in this particular situation?
Basically, our idea is to increase the detection and brings down the false positive rate. So when we take the TR, tricuspid regurgitation, and ductus venosus, it increases the detection rate. But as a fetal medicine specialist, what is most important for me, that it brings down the false positive rate from 5% to 2.5%. So half of the fetuses who would otherwise gone for the invasive testing, so those fetuses can be saved from those invasive testing. So that is why we have to do the complete assessment, where NT has to be taken, nasal bone has as a to be taken, other markers like the tricuspid regurgitation, ductus venosus should be taken, and there should be a complete structural survey where we should look for the soft markers as well as the congenital defects, structural defects.
Wonderful, thank you. So we will follow that routine. And so in her particular case, the nasal bone was ossified. The ductus venosus PI was 1.2, and there was no tricuspid regurgitation. There was no visceral anomaly, and there was no skeletal anomaly. So, and now we go back to this thick nuchal translucency we found in her. Could you reaffirm what the causes are of an increased nuchal translucency, Dr. Krishna Gopal?
Increased fetal nuchal translucency is associated with chromosomal abnormalities, a structural defect, and those genetic syndromes. When an increased NT is associated with the structural anomalies, the risk of karyotypic anomalies is about 5 times higher.
Wonderful. So now we move on to our next question, and that is for Dr. Jyoti Bhaskar. NIPT after this, or a FISH QFPCR, a microarray, culture with karyotype, double marker, or anything else?
As Dr. Sucharita has said, that with the NT of 3.4, we are talking of 99 percentile. So when we have talking of 99 percentile, then what obviously would be the right thing to offer her would be an invasive testing. And with an invasive testing, then we are going to look at what exactly we are going to do. So with the list that you have put across, NIPT, double marker for me are going to be off. I'm going to first recommend her to get an invasive testing. And among the testings that can be done at present, QS-PCR and microarray would be the test of choice that we are going to recommend. These two have got a better detection rate. They would be the ones that would be able to pick up much more. And as you did say in your talk also, that the microarray gives us an advantage of 6% more as compared to karyotyping for picking up the abnormalities. So this would be the method of choice.
Wonderful. So that is exactly what we followed in her situation. The patient was offered invasive testing. The question here was, should we offer a CVS or an amniocentesis? Dr. Poonam Goyal, what are
in this patient, we should offer obviously CVS because patient is 12 weeks, 5-6 days. This is not the right time for doing amniocentesis. CVS is the perfect time for this. CVS should be done from 10 weeks onwards to 13 weeks. We can do CVS. And I think that should be done in this patient. CVS has very less, in expert hands, very less complication rate.
Wonderful. So
one point here, sir. Basically, as I'm doing a lot of invasive procedures, so I face these issues. People read the nets and they are more aware that CVS is having more abortion rate or miscarriages rate than the amniocentesis. So they have actually equal negligible risk. Now with the latest paper, they are having negligible risk. What is more important to counsel is the chances of mosaicism in this CVS. So in my practices, actually, we counsel the patient, and if sometimes patients are adamant to go for amniocentesis because of their belief, we wait till 16 weeks and then we do amniocentesis.
true. And of course, we tell them that, look, we have this confined placental mosaicism, which is rare, and let's see how it goes in this case.
Yeah.
So she opted for a CVS, and CVS revealed a normal QFPCR and a normal microarray. So Dr. Sushma Jindal, post counseling, please, and what follow-up would you recommend?
Yes, in this patient, in spite of having a normal karyotype post CVS, we need informing the patient that in spite of having a normal karyotype, she is not guaranteed to have a normal healthy baby. And the more diligent workup is required because raised NT is an independent marker for associated anomalies as discussed earlier, like structural and cardiac and genetic syndromes. So she should be advised to go for a second trimester targeted ultrasound and fetal echo that is recommended, but that should be taken a little earlier in this patient. So we can start at 15, 16 weeks and then again an MRI scan and fetal echo at 18 to 20 weeks.
Thank you. So that was the plan for her. And Dr. Jyoti Agarwal, is a second trimester triple test indicated here? Is a second trimester quadruple test indicated here?
In this case, the CVS report of QF-PCR and microarray is so reassuring that we just don't need a second trimester test or a quadruple test. As suggested by Dr. Sushma Jindal, we just need a good anomaly scan. Maybe we can do it early at 16 weeks and then definitely at 19 weeks along with fetal echo.
Certainly. Thank you. Dr. Sucharita Jain, an anomalies evaluation at 16 weeks is normal with reasonably decent visualization. What next?
So we still need to go ahead with the detailed anomaly scan as well as fetal echocardiography between 18 to 24 weeks, because the high risk still persists for certain structural anomalies and all, and we cannot forego anything of that. Those anomalies, we go ahead with that, and there are sometimes the findings where the natural history also we don't know, so it's better to play safe and go ahead with both the anomaly scan as well as fetal echocardiography.
Yes, thank you. And this is what we did. She had a normal anomaly scan at 19 weeks, and at that time there was also an echo, and that was completely normal. We repeated everything at 22 weeks. Again, anomaly scan clear, fetal echo clear. We went ahead and called her back at 30 and 36 weeks for growth scans, growth normal, Doppler normal, anomalies review for late anomalies was absolutely normal. She then had a cesarean section at 39 weeks for fetal distress in labor. Healthy female baby, 2.75 kilos, ABGA scores, very comfortable at birth, and an uneventful 4 days hospital stay. And this year at Diwali, she sent me a nice, beautiful dabba of laddu. So, a very nice, happy outcome, truly speaking, because we used our principles. And we realized that not all fetuses with a thick NT are anomalous, that there would be a percentage that would be nice. There is a lot of knowledge to be put into effect. There's a lot of counseling to be put into effect. We must have expertise with the procedure. We must have a good dialogue with the lab. We should have a good lab. And then we say, wow, how wonderful. We can give them a wonderful outcome. Because I'm sure you'll agree with me that it may be the only pregnancy she'll ever have. And we could end up with, for instance, an Asherman's, and then that run of surrogacy and this, that, and everything else. So we really must offer our patients everything on a platter. And any closing remarks on this case by anyone on the panel?
So I want to say that whenever we are counseling, we should harp on all the things, risks, benefits, as well as limitations of the any procedure that we are intending to do, be it ultrasound, be it, and counseling may be pre-procedure or post-procedure. So risk, benefits, limitations, we just cannot take any shortcuts anywhere.
Yes. Wonderful. Thank you so much. And with that, we move on to our second case. And this is a 39-year-old primary, and she presents to us at 12 weeks and 4 days for an early morphology scan. And this reveals an omphalocele which contains bowel. It does not contain liver. The size of the base is 12 millimeters. The nuchal translucency is 3.9 millimeters thick. And the scan shows no other genetic abnormality. And in terms of tricuspid regurgitation or an absent nasal bone or ductus venosus, reduced forward flow. And there are no other structural abnormalities. So my first question here is, Dr. Krishna Gopal, what next?
Sir, I would first counsel the patient that omphalocele is not only a structural defect rather than a soft marker also, and there is a high association of omphalocele with trisomy 18, 13, and triploidy. There is also a risk of non-chromosomal abnormalities, particularly with Widman syndrome and the pathology of cattle. So, I will advise for CVS to this patient's CVS for the confirmation.
Wonderful. So, Dr. Jyoti Bhaskar, the patient in this situation refused CVS. And then she didn't come back. And then she did a Google search and she inspired herself to go to a lab with a GP's prescription. And the family physician said, go get an NIPT done. And the lab belonged to her neighbor's husband. And he was, just somebody who owns a lab. And the result was a low risk. What are your comments on this?
So this is, I think, a situation we all need to deal with every now and then.
Right.
So what we need to tell them, first of all, that this is a screening test. It is not a confirmatory test that she has gone through. Second thing, we need to tell her that NIPT is mainly for trisomy 21. And this particular omphalocele is mainly associated with 18 and 13. And the sensitivity of NIPT to pick up for 18 and 13 is very less, especially for 13, because in that the fetal fraction is very low. And so this NIPT does not have much of a value at all. So I will use this opportunity again to tell her that you are not too late. You can still go on for an invasive testing. If not, she has moved off from 13, 14 weeks, then maybe at 16 weeks, again, I would recommend. If she still doesn't listen, I would just write it on the paper. She has been explained and she's still not willing, and she's aware about the risks of this particular situation.
Well, you see, she feels very confident because now she has this guarantee card, the NIP guarantee card, that your baby is okay and there's nothing wrong with your baby, and NIPT is the answer for everything. So she walks in, and now she comes in at 15 weeks, just on her own, you didn't invite her back. She just says, here's my guarantee card, now what you do. So how do we counsel her now? Dr. Poonam Goyal, she walks in.
She should be counseled again at this time also for a diagnostic test, because in this particular patient the NT is more than 99 percentile. There is omphalocele, age is also not favorable, and the smaller omphalocele we have seen are more associated with chromosomal abnormalities, though we have done NIPT and we have seen that it is not T21. As Dr. Jyoti Bhaskar said, we are still long way to go to find other chromosomal abnormalities. There are 15 to 40% chances of having abnormalities in this particular situation, and at this time when she has come, I would tell her to come again at 15.6 weeks or maybe at 16 weeks for amniocentesis, and before that I will go ahead with the early anomaly scan to find out if there is any stigmata, and also to see if the fetus is still alive or not, because there are situations when if it is 13-18 we are dealing with, there may have been IUD by that time and the patient is taking that NIPT card. So we must do first early anomaly scan at 15 weeks, counsel for that, and then counsel for amnio at 15.6 or 16 weeks.
Excellent. Then I want to know, before we move on to what the results were further, Dr. Sucharita Jain, what are the limitations of an anomaly scan at 14 to 17 weeks? We're going to do it because we know there's enough justification. But after you've done that, what would you still put on as limitations, as you told us earlier?
So because the baby is still growing, there are many lesions which are still evolving, which will present later also, and many lesions they will evolve further. So we have to be cautious and we have to rescan at 18 to 24 weeks. And equally, we have to insist on doing fetal echocardiography.
Yeah. So this is the advice that she was given. And this next question is for Dr. Jyoti Agarwal. She then presents, when would you like to do this anomaly scan? She doesn't want any further testing. She says, I don't want amnio. I've had my 15-week scan, 16-week scan now. When would you like to do an anomaly scan? Would you like to wait till 22 or 24 and say a one-stop shop? Or would you like to say, no, come back at 19. We still want to give you time to think.
I'll ask her to come back at 19 weeks and do a detailed anomaly scan along with fetal echocardiography to be within the legal limitations. Since we may miss out a few of the cardiac anomalies at this time, I can recall her again at 20 to 24 weeks for a second echocardiography.
Yeah. So the interesting thing is that she comes back, and she comes back when it's 19 weeks and 2 days. She just decided that was the right time to come back. And we do a scan, and this time I see an unchanged omphalocele, about 1.5 centimeters at its base, only bowel inside it, no liver, and there is a tetralogy of fallow. No other abnormality. Now she says, now you tell me what to do. So what do we do? Dr. Sushma Jindal, please.
Yeah, it's a big problem for women to take in the information about the diagnosis of fetal abnormality. Therefore, a well-planned and well-coordinated care pathway should be in place. Now we understand she has got two problems which are clearly demarcated in the ultrasound, that is omphalocele, about 12 millimeter, and tetralogy of fallow. In case she has a normal karyotype, both these problems, they are correctable surgically. So I'll try to convince her to go for invasive testing first, so that before any surgical correction is undertaken, we have excluded nicely aneuploidy. That is very much needed in that case. And if she's convinced that she goes for the karyotyping, then after doing karyotype, if that is found to be normal, then we involve some pediatric surgeon along with, so that we get an accurate information whether this problem can be corrected to a near normal anatomy or some palliative surgery will be done. So now onwards, this will be a multidisciplinary approach for her. And now she wishes to continue, then she will be offered one-to-one antenatal sessions tailored to her needs. And also, because both these problems, once the aneuploidies has been excluded, like karyotypically she is normal and omphalocele and tetralogy follow, there can be a strong factor played by the environment. So we ask her to stop any alcohol or smoking if she is taking. And at the end, an important note that she needs to be informed that she would need a delivery in a tertiary care center where the pediatric surgeon facilities are available.
So that was exactly the plan that she was willing to accept. Thank you so much for making it so stepwise and clear. Dr. Krishna Gopal, is it legal to do genetic testing after 20 weeks? If reports are obtained after 20 weeks, is it legal to do these tests at say 19 weeks plus?
Absolute yes, sir. I want to make my audience aware also that there is no law that bar us from doing genetic testing after 20 weeks. And with our revised MTP Act bill in the Parliament, I think it would be more helpful tomorrow if this bill has been passed, and if we are doing this test, then we can terminate these babies also if comes out to be positive. Presently also there is no law regarding the genetic testing that bar us from doing this test after 20 weeks or so.
Yes, and even if the patient opts not to terminate, we know that, as we've already heard from Dr. Sushma Jindal, we need to give her options for the right delivery at the right time. So this patient then says that she wants an amniocentesis. And we do the amniocentesis. The fish is normal for trisomy 13, 18, 21 and the sex chromosomes. There is no deletion in her fish for deletion 22q11. And 2 weeks down the line, a microarray is normal. How is she to be counseled now? Dr. Jyoti Bhaskar, please.
So this is an extremely good news, and I think this is what the patient has been waiting for, that everything as far as the aneuploidies and karyotyping is concerned, that is perfectly fine. And it is comparatively rare for an omphalocele as well as to have an NT to have this particular, but she's a lucky one.
Yes.
So from here on, we start off managing her antenatally, which I think Dr. Sushma has already very well outlined. The most important is we need to again tell her to get a fetal echocardiography done between 22 weeks, a repeat scan at 28 weeks to be able to do a detailed scanner there. And then we need to monitor this patient antenatally. So we are going ahead with the pregnancy. We are going to keep with the pediatric surgeons along with us. It's going to be, again, a combined management between fetal medicine, obstetricians, as well as the pediatric surgeons, and continue the pregnancy further.
Thank you. This is now she was willing to listen to everything that we were telling her, which is nice. Dr. Sucharita Jain, at what stage should we involve the pediatric cardiologist and the pediatric surgeon? Now or a little later? Dr. Sushma Jindal already told us that yes, teamwork is going to save this baby.
So once the decision of continuation of the pregnancy is made finally, then we can involve, because patients and the family, they need some time to get adjusted to the uncertainty that's happened in their lives. So now they need to be reassured about everything, that these two things are, there's no major chromosomal or genetic abnormality. Only these two abnormalities are there which have good life quality later on after the surgery is performed. So once these facts have sunk in with the patient and the family, they have accepted it well, then it's the time to involve pediatric cardiologist and surgeon, because even after, with best of the ultrasound and best of the hands, we may still miss out a minor thing here or there. So they can be ready and well informed. Plus, they should also be involved in the counseling of the patient, because they can be pinked off. The TOF can itself be minor, which can be dealt with easily. It can be severe, which has to be operated in 2 stages. So there are so many things involved with. So patient needs to be informed beforehand, because they are not only the monetary constraints, there are many other constraints also, because initial care immediately immediately after, first thing will be delivery, where to deliver, Dr. Sushma Jindal already said that. And after that, immediate care once the baby and the mother are discharged from the hospital. So both need to be done. So not only the patient, whole family will need to be counseled, and at that time pediatric cardiologist and surgeon need to be there so they can tell the couple and the family according to the needs.
Yes, thank you. So once we are reasonably sure that yes, we all clear genetically speaking as much as possible, scans have come out neat and clean, that's a good time. Say about we got her results by about 22 weeks, and that's when she said, "Okay, I'm now happy." She consulted the pediatric cardiologist. The rest of the pregnancy was fairly uneventful, which was a relief. She consulted pediatric surgery, and she goes into labor. She had already registered at the tertiary care center with maternity facilities, because that's what we'd encouraged her to do, that it's not so nice to do an extra uterine or post-birth transfer. You may as well deliver in a hospital where the surgeon and the cardiologist and the pediatric and the vascular surgeon is available if necessary. And so she did that. At 39 weeks, she had a CS of fetal distress, and the baby had a very uneventful neonatal period. The omphalocele and the cardiac defect were repaired. The cardiac defect was repaired as a 1-stage, and at 1 year, this baby is doing well. So we've already salvaged 2 babies in an hour and 10 minutes. I think that's a good score. That's fantastic. I mean, I do remember that we used to just say, okay, they want a termination. What can you do? And today we say, look, we play on that last 1%, and and we're giving chances of like 20 and 30 and 15%. It's really good achievements so far. But really, of course, the final outcome would depend on the teamwork, as has already been introduced as a topic. And we need that teamwork. It's not available everywhere. We know that all over the world, this is a situation that not all of us can work in royal centers where everything is available and we can sit as a panel. Let the patient move around, let them get their own opinions, let them get a second opinion, and it works. Which brings us to our last and final case, which I call a short case, but that is because the patient decided to be straightforward about it. And this is a patient who presents at, she's 27 weeks. She's had an IUI after which she conceived. It was for an unexplained infertility. And she comes in at 12 weeks, 6 days. And the nuchal translucency is 4.4 millimeters thick. So the situation is, Dr. Poonam Goyal, what next? What else should be included in her scan so that we can do it right? I know we're repeating ourselves, but I think there's lots of people with us who would like to have this message to take home.
Sir, after your enlightening talk and discussing 2 cases, I think 200 people who have logged in all will have one answer, that we need a diagnostic test for this particular patient. Yes. If the NT is 4.4, it is obviously more than 99%, and if NT is more than 99%, and already this is a kind of precious pregnancy, in this particular patient, there are chances of having 70% chances of having a normal karyotype in these patients, but still there are higher chances of having structural abnormalities, around 10% structural abnormalities, and 20% chances of having chromosomal abnormalities, and I think 2-3% chances of having IUD also in this particular patient. So we need a diagnostic test in this patient, as well as we need to evaluate it for tricuspid regurgitation and DV, etc., because NT is increased, and we have to take fetal echo and her other things also we have to take. So we do that only, and biochemistry we need for placental function.
Yes.
I think in this particular patient will need a detailed evaluation with ultrasound plus biochemistry, plus we should do CVS in this particular patient.
Wonderful. So in her situation, she opted for a CVS. Yeah. And she's Rh negative and on 75 milligrams of aspirin by her infertility IUI specialist. And so then the question was, how how many days before invasive testing should aspirin be discontinued? And what is the recommended prophylaxis for this patient for her RH? Her husband is RH positive. This question is for Dr. Jyoti Agarwal.
As far as the RH incompatibility and the recommended prophylaxis is concerned, she definitely needs anti-D injection of 300 micrograms intramuscularly. And as far as the aspirin is concerned, the guidelines on the aspirin say that 75 milligrams is anyway a very small dose, so it need not be stopped. But since it is a precious pregnancy and I don't want to take any risk, I'll stop 1 or 2 days prior to any invasive test.
Yeah, so that's what we did. With CVS, so the QFPCR positive for trisomy 21. And so we heaved a sigh of relief actually, because this was a sensible girl. She knew what life was all about. She said precious pregnancy or no precious pregnancy. I didn't even need IVF. I managed with an IUI. I know my doctor will guide me through an IUI again if necessary. And my doctor told me that you may not even need an IUI after unexplained infertility. So she terminated that pregnancy. And she was well protected. And then we say, okay, in this situation, we have a nice take-home message for everyone that the invasive testing is the ideal option, gives us the quickest answers. Yes, sometimes it throws us into what we've just been through in the last 2 cases, but a lot of the cases are straightforward and we have an answer. And with that, I'd truly like to thank our panel for guiding us through these 3 cases. You all were absolutely brilliant. I must admit, we'd shared these questions earlier to make sure we could finish in the time allotted to us, and it seems to have worked well. Thank you very, very much to each one of you.
Sir, in the chat box, there are many interesting questions.
This is what I was going to say.
Take those questions.
I want to stay on, and we move into our chat box, and then we say, all right, we'll be able to answer those questions, and then go through and see how much we can answer. And the panel can perhaps help us with this. And I'd request our chairpersons also to be with us to be able to give in their advice. What do you think, Krishna? Would that be good?
Yes, sir.
Yes. I'm starting at the beginning of the chat box. And there is one question from Dr. Kishore Rajurkar. And he had asked whether instead of a dual marker, should we not do NIPT plus NT-NB and early anomaly scan? So, Dr. Jyoti Bhaskar, what is your input on this?
So I would like to hear the question again.
Yeah, so, what we had suggested was that we do a dual marker for placental function when we have that, when we do the NT-NB scan and the early anomaly scan. So, should we do, instead of dual marker, should we do NIPT?
So if we have done an extremely good scan, then dual marker would be good enough to do along with that. Because with a very good scan plus dual marker, we're reaching a sensitivity of nearly 97% with a false positive rate of only 2.5%.
Yes.
But as you did say in your of this, if the patient is economically very good and we are living in a developed country, then probably we can also combine NIPT along with the combined test.
Yes.
That can be offered. But otherwise, I think the combined test in good hands would be good enough.
Of course, the question here was whether we should skip the conventional biochemistry altogether.
It should not be skipped, sir, because we need to know the function also. Sometimes the PAP is very less, it is less than 0.4. That definitely suggests that there has to be some placental factor as the eventually pregnancy goes on.
I would agree there, yes. And Dr. Puna, would you not agree with me also that we'd also like to add on PLGF, since truly speaking, preeclampsia is so much of a greater problem than the aneuploidies.
The PLGF cost is little high, but I think if the cost factor is not there, then PLGF should be done.
Yes, we can offer it to them.
Yes, we should offer. Yes.
But we shouldn't be skipping this. Yes.
But I think the PLGF, if you add on, the cost will be less than the NIPT.
Yeah,
It
yeah.
will be less.
It will still be lesser.
Yes.
Combined test, and yes, it still be lesser.
Lesser than NIPT.
Yeah.
NIPT.
Yes, NIPT, of course. Combined test
No,
with the PLGF.
Combined test along with PLGF, it will be less than the NIPT.
It's 3,000 and शायद PLGF के अलग से 3,000.
Yeah, but what we have
No,
also
but less than the Nifty, no?
हाँ हाँ NFPT से बहुत कम है.
I also discovered by chance, and this is very interesting, that when we do a penta, it includes the PLGF, and the penta is actually cheaper than the double marker plus PLGF.
Correct.
So I said, wow, that's a great bargain. I haven't funded
How
it.
much that penta cost?
But the fact is that the penta is actually working out cheaper in Delhi than the biochemistry plus. So of late, I've been telling everybody, just let's do a penta.
Better to go
So
ahead
how
with
much
that.
it costs, Dr. Ashok?
Validated. I'm going to find out, but I know that they've added on. It's just about 800 rupees or 1,000 rupees more than the double marker.
Very,
Acha.
Yeah.
very fine.
Who is doing it?
Such a bargain. And
Who
we'll
is doing
work
it?
on them, and we'll ask them to distribute.
Price sell करती है मैम.
Sir, I wish to tell you that, the Lals are offering it, and to
नहीं.
our clinic, they are giving it for 3,000 rupees.
Yeah, so that's
नहीं
now.
ma'am, Dr. Lal's lab is not doing penta marker test. I have inquired it many times from them. मैंने उन्हें suggest भी किया है. I have even talked to their person also कि भाई जब सब करते हैं तो तुम क्यों नहीं एक panel बना सकते? You are doing PLGF, you are doing dual, you are doing every test. Make a panel, सस्ता कर दो. नहीं हमारी बात चल रही है, हमारा कोड बनेगा, लेकिन कुछ नहीं हुआ है. I have talked twice.
PLGF वगैरह वो करते हैं डॉक्टर साहब?
हाँ जी करते हैं मैम, अलग करते हैं.
Individual
combine
करते हैं,
करते
मैम,
हैं.
हमारे को एक साथ देते हैं पैसे, 3,000 रुपए में करते हैं हमारे यहाँ.
हाँ 3 में ही करते हैं मैम.
Society of
That's good news. So I think we'll encourage a few more of these labs to do so.
working with many labs to make them aware about this penta screening.
Sir, can we use this platform to also highlight what would be the best platforms to do our biochemistries, or can we do it like we have the Roche, the Delphi, or we can do
Sir,
it
in
on
the
any
chat
platform?
box, doctor from the government sector, Dr. Rajulkar asked that they see 500 people. The question of this investigation is not possible. What do you suggest? There are many questions, but they're in the periphery. They are just not doing these kinds of things. So, what is your suggestion?
I would like
100 people in the city. You must address, the thousands and thousands of doctors.
Ma'am, in those particular patients, we can go for uterine artery Doppler. Sensitivity may be little less than PLGF.
no. I've got an answer to answer this question.
Yes, ma'am.
Like what the latest National 2020 Rare Disease Policy says, it says that the optimal screening is to be done. That is where there is a family history of a congenital malformation or a disease, and it has been confirmed, the diagnosis has been confirmed. There only the testing of invasive testing has to be offered to the client. So in a government setup OPD where we are dealing so many number of patients, we have to have the high risk screening, and where there is a history, we have to go for further screening.
I think we have to clarify the words there a little bit. Yes, that is for invasive testing, but we must tell our patients that, look, you have come to a government hospital.
Yeah.
Government hospital, we have restrictions on money, we have restrictions on expertise, and our workload is large. What we will do is an NT scan, because that is within the reach of this institution, and therefore the detection rate in this case would be about 80 to 90%, or maybe 80, 85%, or 75 to 85, depending on our expertise. So we have an institutional protocol. On the other hand, we have to tell these patients that, look, privately, you can go and see what you get, and it is possible by adding on to this test. So we have to have a little more time spent in counseling. We should train the people who work in our OPDs as paramedical staff to counsel on our behalf, to say that, look, you can get a greater accuracy rate, but that would not happen in this institution, and the choice is yours. We must give that choice to the patient, because not everybody who comes to a government OPD is necessarily empty pockets. And there are lots of people who, should I say, misuse the facility, but everybody's entitled to a government facility. So we must put everybody into the cafeteria approach. This is available, and this is an approximate cost, and you can go and find out for yourself. This is what we do in our institution. It works very well in many parts of the world with an economic disadvantage, and this is what we are offering, and so on. And then the ones who opt in or opt out is then depending on their own assessment of their own status and their own fear. That is important because for Down syndrome, for instance, we don't have to have a family history, and yet it's the commonest cause of
Cause of genetic problem.
Yes. And the same thing again applies for a lot of our cardiac defects.
So that means when in low resource scenarios, our counseling should be more structured. We
Yes.
should know what points we must not miss. So we should be talking of risks as well as benefits and limitations within the shorter time. So it has to be structured counseling.
Every institution must have a clean institutional protocol.
Yes.
And the responsibility of the administration of that government institution.
True.
We have got guidelines with this from the health ministry that came out. Dr. Pratima Mittal and her group had worked on this and said, look, the only scan that we can promise definitely is 18 to 20 week anomaly scan.
Yes, agreed.
There were options, and that should be told to the patient that, look, you can get this done if you wish. We cannot afford it at the government level, but you can decide on your own if that is so. And that is something for the patient to decide, no doubt about that. There are a few questions in the chat box that are not directly relevant to the thick NT, so we'll move on to the ones that are more relevant. And there was one very nice question that said, in India, it is easy to advise termination as compared to the West. And in the UK, of course, a lot of people would continue. And I fully agree with that statement by Dr. Rajurkar that yes, a lot more people in the West would continue to do this. Roman Catholics sometimes would continue to do this. Other religious communities would decide to continue. And the facility available for the psychological and educational support for these individuals is much more. The facilities available for individual dignity and respect is much more. And we have a very harsh society that we live in, and therefore we must warn our patients about this, that yes, if you can immigrate to Canada, that's an option, and you will be well respected. After all, there are people who have that option. We have to really give them a wider basis, and we think that over the years, we will develop at the Society of Fetal Medicine good counseling points. And we made a start today, and we'll work on that. And therefore, we say, okay, in our counseling, we will include what we can do in the institution, and we will then say, look, the patient can opt for this at our institution. This is our limitation, which answers the question that Dr. Adira Rajendra had actually said. We'll skip a question of fetal MRI, but we'll move on to another one. And the question is, in the periphery, nobody ever tells patients about aneuploidy screening. If anything goes wrong, how much are we legally liable? And we do understand that this happened in Jodhpur a little while ago, that the patient said that the doctor said not. It is important for all of us, and I'm sure my panel would agree with me, and our chairpersons would agree, that in terms of counseling our patient, we cannot afford to be judgmental. And we have to put everything on a platter and say, look, this is my menu. You've come to McDonald's, you choose this. You come to KFC, you choose this. You come for a Pepsi, you choose this. You come only to an ice cream parlor, you will only get ice cream. That kind of an approach becomes necessary. Would the panel agree with me on this?
Correct.
So that's why I was insisting that while counseling, we must put down on papers limitations also.
Yes, absolutely. And institutional policies as well.
Yeah, because screening
Sir,
is
I have made a
23%.
like or information paper in Hindi,
Yes.
telling everything about all these tests, and then patient has to first read that paper, then sign it, then give it to us, then we do for then we go for the scan. I can share that paper in my group. I'll share.
I think that would be very nice.
Sir, my request to you is that, we must come out with some paper, 1 page or 2 page, both in Hindi and English. And that can be
मैंने मैम
circulated
हिंदी
to the
इंग्लिश दोनों में ही
reporters
बनाया
gynecologist.
मैं कल भेज दूँ
And then along with a good picture of the NT, we will put this all together and we will distribute it to all our members and make sure, and for anybody else who wants it on that table, so that we can use these counseling points on one side, limitations on the other side, and a possible approach.
And the refusal also should be informed. It has to be not only informed consent, refusal also. When patient refuses also, he or she should know what she or he is refusing.
Yes.
But this type of exercise is not possible in a government hospital.
Government में तो possible.
Ma'am, if you have a structured approach, it is possible. If you make columns and you just one junior person sits and ticks it out, that yes, you have to get, then it is possible.
Yeah.
Ma'am, initially when we started, even PNDT form filling was not possible. Now we
I
have
think, There are senior people who are from the government sector, 500, 600 people. There is a line which is going, almost, within the whole hospital. It is not possible. And I'm telling you, I train people in infertility and other things. People in the periphery don't know anything.
Even when there is a
आज की तारीख में जब live webinar होता है, उसको पहुंचाने का means है, and this is the time must be utilized.
Yes.
How we can, in this particular panel, the evening also we had put it, and there are people from every
Corner.
area. The people have joined here. So that's the power of the live webinars.
Yes.
People have an access to things. So what
Sir,
I'm seeing,
Ma'am, the whole education system is on internet nowadays. So why can't we teach our junior doctors or support
डॉक्टर साहब,
staff?
आपको गलत फहमी होगी सुचरिता. यूपी में से आती हूँ, वहां पर एक भी स्कूल में कुछ नहीं हो रहा. दिल्ली में हो रहा है, वहां नहीं हो रहा.
I think each one of us has to inspire our leaders as well. And we have to inspire our bureaucracy to move. It's not an easy task. I remember when ultrasound first came to India, my first talk in the early 1980s was indications for ultrasound. And we struggled and we struggled and we struggled. We used to make our own slides. 7 indications for ultrasound, not obstetric ultrasound, indications for ultrasound. And within a decade, we pushed it.
Sir, we have seen that time. हमने तो अल्ट्रासाउंड, जैसे मैम कह रहे हैं ना, हमारे तो इंस्टीट्यूशन में अल्ट्रासाउंड होती ही नहीं थी. हम तो पढ़ के बाहर आ गए, तो बाद में हमें पता चला.
10 साल मैंने पीजीआई में लगा, हमने अल्ट्रासाउंड ही नहीं देखा.
मैम जी सबके साथ था. Even we studied in medical colleges and there was no machine.
We will push as a society.
Yes.
So that we can do it, because there is a very gloomy note that Dr. Nikita Jain has sent us. She says very few government hospitals do a decent job, leave alone NT and B. And she says universal screening is not possible. I think universal screening is possible. We will take the initiative. We will work hard. Each one of us has the passion and the motivation. We have the leadership. Dr. Shada Jain's message about mixopathy has reached every doctor in this country.
Yes.
Every
Right.
group that I was on, doctor or no doctor, I put it there because there was so much passion in that. And believe me, we've moved mountains with that one message. And if we have more like this and we have leaders like her, I'm sure we can do extremely well. We have workers like all of us over here and leaders like her. It's a perfect combination. I know that that we will manage universal screening sooner than later.
Sir, both ways it works, from above downwards and from below upwards. So don't worry. Both models
But
will
what
work.
I feel is the drafts have to be made both in Hindi and English, and everybody tries to say 100 people decide कि हमने सब जगह पहुंचना है, तो पहुंच जाएंगे. 10% में पहुंचेंगे, फिर 20% में पहुंचेंगे. मैं तो खुद ही देखती हूँ डॉक्टर साहब, कहाँ एक स्कैन से लेके आप वो लेडी का एंड ही नहीं है, अल्ट्रासाउंड होते ही रहते.
And this business of CGHS rates, etc., people are managing quite a bit.
They're managing ultimately.
Yes. So I think we're through with the questions in the chat box.
Okay.
So back to Krishna.
Sir, I have one question.
Yes.
Please, if I have done combined screen, everything, my NB, DV, TR plus dual marker, and I have a risk on my table. In that particular patient, can I do the next scan at 22 weeks to 24 weeks, in between 22 weeks, so that I can see the heart better and do it at one time only instead of calling the patient twice? Is it rational or is it out of the box?
I'll tell you the problem, that it's out of the box thinking, but there's a rationality to it in the sense you need one scan. Unfortunately, the rule that we have, the one that Dr. Jaideep Malhotra and I had worked on with the ministry, we had this notification that came out last year at the end of September, which clearly said that if we find anomalies beyond 20 weeks, and we didn't define the upper end, where the quality of life of that fetus is likely to be compromised, then the patient can appeal to the district court, not the high court as earlier, the district court, which will then send it to a government institutional expert body who have to give back the results. And within a week of that appeal to the district court, the district court has to give a judgment that this pregnancy can be terminated. So truly speaking, because we are seeing much more at 22 weeks, that should be our point. None of this is included in the new MTP Act. The MTP Act is silent on ultrasound abnormalities. We will continue to use this particular guidance note by the Health Ministry. It's been used. We've had 11 cases in West Bengal. We've had 20 or 30 cases in Maharashtra, and we've had scattered cases from every state now, where the district level court has been shown this judgment. We have lawyers that we know who do this at a very reasonable cost, and we are achieving it. So ideally speaking, yes, 22 weeks, but there is a hassle with the courts. There is a hassle with the patient psychology, and there's a general hassle when we handle government machinery. So from a practical point of view, 19 seems to be a better answer.
And also with the fetus, sir, sometimes fetus won't turn around very easily at 22 weeks.
Sometimes they do, but
sometimes yes, sometimes no. If the liker is limited, mother is obese, it becomes all the more painful at 22 weeks.
So we're waiting for this MTP Act to find its new level, and then we'll see, okay, now
then we can decide.
Note into further law, so we don't have to struggle with this. But we have any government institution, because okay, you don't trust a private institution, but at least you can trust a government institution.
And sir, there is another problem. If I am doing a Doppler scan, patient has come to me for this first scan only. I have not done her earlier scans. And she is having a 2-3 line report of your 18 to 19 week scan and nahi hua is these kind of patients. When I do Doppler scan, legally am I bound to see every abnormality? Because बहुत difficult हो जाता है, that Doppler scan becomes a pain in the neck. If you have to see all the abnormalities.
We try and see them because we have to spend time with the patient, but we
can make a note. I have seen kidneys, I have seen 4-chamber heart, and I have seen this I could not see. That note can be made.
The question is that an attempt was made to look for anomalies. This was limited by advanced gestational age,
we can put that kind of line.
And fetal attitude. So we must mention that in the body of our report. But you see, the thing is that if we do find a lethal abnormality, then there would be that possibility that you and me might want to avoid a cesarean section on an abnormal fetus. So it's not that we should not attempt to look at all.
वो तो है sir, कोशिश करते हैं, but still it becomes sometimes little difficult. Then legal foundation हो जाए तो I had one incident I would like to share. एक patient का मैंने sir combined marker and everything करवाया. When they came with the report, their risk came out to be 1:2000 something ऐसे कुछ. And that man, he said, I counseled that there are this much chances of having a Down's baby. कह रहा क्या बता रही हो मुझे, मैंने पढ़ ली सारी रिपोर्ट. क्या बता रही हो आप मैडम मुझे, मैंने सारी पढ़ ली रिपोर्ट, मुझे तो पता है बच्चा डाउन्स है, मुझे तो पता है, आप मुझे क्या बता रही हो. अरे मतलब he was on my head. मुझे आप क्या बता रही हो, मैंने तो पढ़ ली सारी रिपोर्ट. ऐसे ऐसे करके उसने मुझे सर कहा. मैंने कहा भैया एम्स चला जा.
You know, that's a mindset that we have to struggle with all the time. Yes.
Sir, मुझे आपसे एक request करनी है, which is not related to this panel.
Yes, ma'am.
That there are a lot of litigations against the ultrasonologists as well as gynecologists. They are doing a level 1 scan, and the things have been small things have been missed out, and they expect 100% thing to be there.
Yes.
Just like the UK guidelines, they have enlisted 11 things, that even anencephaly can be missed in 2% of cases. Cardiac anomalies can be missed in 50. Something of these guidelines, I think, should be from your side, that these things can be missed out. So we can give it to this MCI and things like that. Like in MCI, in my time, in 3 years, we could, clear away all those cases which are pending against the doctors. But the question is, MCI is not listed like a High Court judgment or a Supreme Court judgment. So, we should have something in detail. We should be really publicized, on the similar lines. So once it goes there, because वो तो जब बात करते हैं तो वो तो एक छोटी सी अनामली को पकड़ के भी डॉक्टर से करोड़ों रुपए वसूल कर रहे हैं.
हाँ बिल्कुल.
वो एमसीआई से निकल जा रहे हैं तो वो दूसरे वाले कोर्ट में डाल दे रहे हैं डॉक्टर साहब. तो आपका एक बहुत अच्छा सुंदर सा निकल कर आना चाहिए डॉक्टर साहब.
We will do that. We have it ready.
The children are thriving well. कुछ नहीं हो रहा, कोई हैंडीकैप नहीं हो रहा. वही कहते जी हमारे बच्चे को हैंडीकैप बना दिया, इसने ये कर दिया करते. उसमें बहुत तंग हो रहे हैं डॉक्टर साहब.
And
something has to be done, sir. आपकी जब तक स्टैंप नहीं लगेगी ना तब तक कुछ नहीं होगा.
We added this to the MTP Act, where it was a list of findings that can be missed on an ultrasound scan and the accuracy of ultrasound in various studies, even in Europe. That has got bogged down in the MTP Act, but you're absolutely right that if we have a statement by the Society of Fetal Medicine, we can say that yes, we will get it endorsed by everybody. We'll get it.
Sir, I will get it a meeting arranged for you for in MCI, where you go as an expert, and something should be documented at MCI level. Things will be done.
I will prepare the document, and then we will go and meet them, and we will do this.
Yes, thank you so much, sir.
A pleasure indeed.
Great.
So that was, and
It was a great show of Dr. Ashok and Dr. Gopal both.
Madam ka bhi
And all the panelists.
Together, yes.
And the words of Dr. Shada Jain is super. I think that has to be implemented practically.
My words, I in a healthy way, because they gave me 10 minutes time, so I was a little critic. But I think, it is good to be critic, where we are, we must know about it.
Yes.
You must, ma'am. You must. Thank you so much, ma'am, Shadajan, ma'am, sir, Dr. Ashok Khurana, sir, and all the faculties on the board. I'm thankful to my society people also, Bishalji, our backbone, and Conference International, who is always there for us, and all the officials of Delhi Gynae Forum who were kind enough to arrange this meeting for us. Thank you so much. Happy learning. Bye-bye. Good night.
And all senior people had been there across the city.
Thank you very much.
Thank you, sir. Thank you. Thank you, ma'am. Thank you, sir.
Thank you.
Thank you, everybody. Thank you.
Thank you.
Thank you, Krishna. Bye.
Good night, all. Good night.
Good night.
Thanks. Good night.
Good night.